My name is Siwen-Hu Liskoven. I'm a medical oncologist and faculty member at the UCLA Medical Center. I specialize in immunotherapy-based clinical testing and basic research in solid tumors. So the CheckMate 026 trial is a phase 3 clinical trial testing a anti-PD-1 immune checkpoint inhibitor, nivolumab, versus the standard of care chemotherapy in patients with non-small cell lung cancer. Now, this is in the frontline setting, and the patient has to have tumors that express quote high level of PD-L1 expression, and the cutoff is 5%. Now, the press release from Bristol Myers Squibb recently indicated that the trial did not meet its primary endpoint, which is the progression-free survival. Now, I consider this is the failure of the trial, but not the treatment itself, because progression-free survival is not a very good endpoint in immunotherapy testing. The previous trials have proven many times that it's not a good marker to indicate the efficacy of immune therapy. The first checkpoint inhibitor, ipilimumab, that is a anti-CTLA-4 antibody, the phase 3 trial that led to its approval actually had to change its primary endpoint from progression-free survival to overall survival in the middle of the trial. So there are many reasons why progression-free survival is not a good primary endpoint for immunotherapy testing. But from a medical oncologist or cancer immunologist point of view, I think it's due to the mechanism of action of immunotherapies. So immunotherapy actually, we are using immunotherapy to activate the patient's immune system against the cancer. So in many patients, this process takes time. So the patient's immune system has to be activated first to be able to recognize the cancer, and the immune cells proliferate and then kill the cancer cells. And it's a dynamic process. It has to overcome the fast growth of the tumor. Versus the chemotherapy, it's a cytotoxic agent, and it just kills the cancer cells immediately. So in many patients, actually, sometimes we see the growth of the tumor first, and then later on the immune system can take over and then eventually kill the tumor. So if you only use progression-free survival, you actually miss those benefits, those efficacy in those patients. And another reason that this trial failed is because of the biomarker they used. So they used the PD-L1 cutoff of 5% of positivity. So PD-L1 is a very controversial biomarker to predict the efficacy of anti-PD-1 and PD-L1 antibodies. It's mainly because even PD-L1 negative patients, they can have response to anti-PD-1 therapies due to a process called adaptive immune response. And also, there are a lot of heterogeneous testing. The testing of anti-PD-L1 therapy is very heterogeneous. The assays used and the cutoff are all different across different trials. So it's by itself, PD-L1 is a poor biomarker to predict the response to anti-PD-1 therapy. However, it's been proven that PD-L1 expression level does correlate with the possibility or likelihood that the patient will respond to anti-PD-1 therapy or not. Those patients who have very high PD-L1 expression in their tumors are more likely to respond to anti-PD-L1, anti-PD-1 or anti-PD-1 therapy. So in the in the Merck Keynote 024 trial, which has a very similar design to the Checkmate 026, in that trial, the anti-PD-1 therapy used was pembrolizumab. And the patients were randomized to either Keytruda or pembrolizumab or to standard of care chemotherapy. And the cutoff of PD-L1 positivity was 50% or more. So the primary endpoint of that study was also progression-free survival. And the press release by Merck a couple months ago indicated that the trial actually met its primary endpoint, the progression-free survival, and the secondary endpoint, which is overall survival. I think the difference here is the higher cutoff of the PD-L1. Of course, we don't have the actual data. These are all press release, and we need to have the real data to study the detailed information. There's another Bristol-Myers Squibb trial, which is the Checkmate 227. So that trial is also a phase 3 trial, and the difference here is it's study the patients in two different cohorts, those with high PD-L1 expression and those with low or no PD-L1 expression. And in the cohort with higher PD-L1 expression, the patient will be randomized to either nivolumab alone, nivolumab plus ipilimumab, or the patient might get standard of care chemotherapy. And in the patient who have low or no PD-L1 expression, the patient will be randomized to either EP plus nivolumab plus chemotherapy or the standard of care chemotherapy alone. And the primary endpoint would be both overall survival and progression-free survival. So the data from that trial will be very interesting. So again, I think the failure of this trial doesn't indicate the failure of the treatment. Overall, we in the second-line setting, we have seen very good efficacy data with either anti-PD-1 alone or anti-PD-1 in combination with anti-CTLA-4, which is ipilimumab, and which led to the approval of nivolumab and pembrolizumab in patients with advanced non-small cell lung cancer in the second-line setting. And the therapy itself is very tolerable, and the most exciting part is the durability of the response. Majority of the patient, or a lot of the patients who have the benefit from the treatment, can keep the benefit and can survive for much longer period than with chemotherapy alone. In the future, I think we can use PD-L1 as a biomarker to select the patient who will most likely respond to single-agent anti-PD-1. And for those patients who have low PD-L1 expression, who are unlikely to respond to single-agent anti-PD-1 or anti-PD-L1, we can use combination therapy to improve the efficacy. And the most recent released data from Checkmate 012 presented at ASCO 2016 indicated that the combination of nivolumab, standard of care dose of nivolumab with lower dose of ipilimumab at increased interval, it has better efficacy and also better tolerability, and that's that's one of the possibilities of combination therapy. And there are many other immune checkpoint or immune modulatory agents that being developed and can be the agents to be combined with anti-PD-1 therapy.